Hello and welcome to the Processes and Documentation in the Obstetrics and Gynecology module. Here we will begin by looking at admissions. So the first section of Processes and Documentation which you will need to learn is the admission clerking. This will be one of the core tasks required from you. Having good documentation skills and clerkship skills are going to be an advantage throughout your training. Patients from the obstetrics and gynecology divisions are admitted either from the emergency department or outpatient ONG clinic, early pregnancy assessment center or known as EPAO, and from the labor room. Certain hospitals may also have an area called the high risk area where pregnant ladies' comorbidities which are causing them problems now are admitted and monitored closely. Once the patient is reviewed and admission plans are ordered by the attending team, nurses from the respective areas will arrange a bed by liaising with the ward nurses. Once the bed is ready in the ward, the patient will be sent up to the ward. Admission docket will contain the patient's admission slip, payment receipt, and clerking document done by the doctor attending from the mentioned areas. On arrival to the bed, the nurse in charge will ensure that the patient is safely transferred to the bed in the ward and will take the vital parameters to be recorded in the observation chart. The nurse will also inform you that the patient has arrived and ready to be clerked or attended to. So what is your role here as the ward house officer? As the house officer, you play quite an important role in clerking the patient's history, performing physical examinations, ordering the investigations including the lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from senior colleagues or from your team members. Admission clerking, as the name suggests, is carried out for the patients who are admitted to the ONG wards. The house officer in charge of the new patient who is being admitted is expected to review the patient within 30 minutes from the time of admission. Review the clerking which was done earlier in the clinic, emergency department, or other places that would be further discussed and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Review the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, alert your medical officer or specialist immediately. Usually, your medical officer will receive a referral call from the ED medical officer. Sometimes, you may be in charge of the ED referrals for that day or may also be hand-chosen to see the patient first. Therefore, you will need to do a detailed clerking and perform necessary physical examinations as well as trace any investigations done by the ED team prior to your MO's arrival. Most cases referred from the ED may have slipped from EPAO or would be the ones who would be with hemodynamic instability, for example, ruptured ectopic pregnancy, ruptured or twisted ovarian cysts, to name a few. The patients who come here would be for early pregnancy assessments. In other words, EPAO is also an emergency section for those who are still able to walk in. They could be ranging from 12 weeks up to 24 weeks of gestation age. In this section, the usual cases that you will come across would be pervaginal bleeding, miscarriages, hyperemesis gravidarum. So here sometimes your medical officers may even check for fetal viability as well. Here, once you are done with your clerkings, you will be assisting your medical officers with many procedures as well. Next, the high risk. In the high risk section, they are usually those patients who have been seen in the EPAO or even referral cases from Klinik Kesihatan or even general practitioners. The type of cases here would be gestational hypertension, pre- or eclampsia patients, anemia in pregnancy requiring blood transfusion, and many more. When you are in charge of this section, you may need to do regular follow-up and monitoring of the patient's progress besides only clerking. Next would be PAC, which is the Patient Admission Center. As the name says, this is a center for the patient to be assessed prior to admission. Some patients will present with contractions or even leaking liquor or those who are already in labor. You will be in charge of going through their antenatal book and quickly clerking so that when your medical officer comes along, they are ready to check on the opening of the os or scans and prepare the patient for the delivery. Next is the labor room. So the labor room is the place where a lot of happiness is seen. Yep, as mentioned, you get to see the joy from the parents upon welcoming their newborn. So here the cases which come in would be the ones who are already in labor. You will receive these patients from the PAC usually. Therefore, your colleague would have probably clocked the patient, but it would be important to roughly go through their history again. You will be plotting the pathographs and documenting the patient's progress from time to time. So when you're done with your clocking and physical examinations, you will need to present your case to the medical officer or specialist who comes in to do the review. Do make sure that you do not make up points to say if you're not sure only because you're afraid, because every detail may play a very important role. Write or type out every point and plans given by the medical officer or specialist. Try not to take risk by just remembering the verbal orders. Once the patient is seen with the MO or a specialist, always write their respective names on your clockings or reviews, such as seen with Dr. A, discussed with Dr. B, or attended with Dr. C and Dr. E. Documentations are the utmost important, therefore, pay attention to every single detail written or typed. Next would be a case presentation. So case presentation is a formal communication between the healthcare professionals regarding a patient's clinical information. It is the job of the presenter to share the pertinent facts of a patient's case with the other members of the medical care team and establish a clear diagnosis and treatment plan. So in your housemanship training, you will be delivering many case presentations as your communication with your superiors begin here. So while delivering oral case presentations is a core skill for trainees and there have been attempts to standardize the format, expectations may still vary among attending doctors. So this can be frustrating experience for trainees, and I would recommend that you clarify your attendings' expectations at the beginning of each rotation. So how do we present a case? The clocking in this department may vary from the others. You will need to present cases with a lot of dates and past events of the patient as every point would be very much related to their current pregnancy or even gynecological status. First, we will be showing you the general flow to clock these patients, and then we'll give you a few case samples for your better understanding. Let's begin with the opener. You should begin every oral presentation with a brief introduction. Remember that the chief complaint is the reason that the patient sought medical care in her own words. This would include the patient's name, gender, and also the age, the gravida and parity. Gravidity depends on the total number of pregnancies regardless of its outcome, whereas parity depends on the number of stillbirths delivered after stage of viability, which is 24 weeks and above. Last menstrual period is known as LMP, which is the first day of the last menstruation. Expected date of delivery or EDD, period of amenorrhea POA and gestation POG, date of admission or date of delivery and date of operation. I'm now going to show you a few examples of presenting an opener. So a patient on a first pregnancy would be G1 para 0. A patient who had a pair of twins before and currently pregnant would be G2 para 2. A patient with history of 2 miscarriages, had 1 stillbirth child and currently pregnant would be G4 para 1 plus 2. So once the patient has delivered, don't forget there would not be a gravida any longer but would be added to the parity. Next would be the history of presenting illness. Elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. The important points you would need to include would be if the patient had any contraction pain, did the patient present with leaking liquor. Also important to know if there was any show present. Next would be if the patient has any antenatal pyrexia. How is the fetal movement based on their fetal kick chart? And is the patient well today or with any signs and symptoms of urinary tract infection? Next would be the past obstetric history. Here you would need to include on the years of delivered, most importantly the last childbirth. Type of delivery, whether was it a spontaneous vaginal delivery or a lower segment cesarean section. History of miscarriages or ERPOC, which is removal of the product of conception. And also do ask the conditions of their babies post-delivery, such as their weight, their gender, and their viability. Next, we move on to contraception history. This would be important for gynecological cases as well. You'd want to find out how many children do they plan for, which form of contraception are they practicing or intending to use, and are they aware of the side effects and complications as well as the advantages of contraceptions. The past and medical and surgical history will then follow, and this should include the following information, which are the patient's medical condition, any past surgeries the patient has had and when they had performed, the timing of and reasons for past hospitalization, and any current medications including dosages and frequency of administration. Next, similar to other clocking sheets, we have the family history. So any relevant conditions that run in the patient's family with an emphasis on first degree relatives. Social history would include the section about the information about the patient's living situation, just marital status, occupation for both the patient and her husband, any alcohol or tobacco use or other substance use, the domestic condition, and the sexual activity. Next would be physical examination. So once you have finished reporting the patient's history, you should then transition to the physical examination. You should begin by reporting the patient's vital signs. You should discuss the findings of your physical exams. At the minimum, this should include your general impressions of the patient, including whether she appears sick or not, and start with physical examination of the pregnancy using the Leopold's maneuver or abdominal and vaginal examination. Now let's take a look at a few case examples. This is a case of a patient who presented for labor. This patient is born Cindy, a 29-year-old, Gravida 2 Para 1 at 38 weeks plus 1 day gestational age. Her last menstrual period was on the 29th of November 2020 and the estimated date of delivery or EDD is on the 5th of September 2021. Antenatally, it was uneventful. So patient came in to the PAC on the 23rd of August 2021 at 6 p.m. for lower abdominal contraction pain associated with show. She denies any gushing of fluid, no fever, URTI or UTI symptoms. Her last childbirth was 3 years ago. It was a spontaneous vaginal delivery and it was uneventful. The child is well currently with a birth weight of 2.8 kilograms. Patient has no underlying medical history or no past surgical history as well. Patient is currently not working. Her husband works as a pilot and there's no history of genetic disorders. So on examination, she was found to be alert with full GCS, pink, not pale, not tachypnic, however found to be slightly tachycardic. The CVS and lung examinations were normal, and here you'd want to describe abdominal examination relevant to the patient's complaint. So the abdomen is soft, non-tender to palpation with no mass palpable. The fetal head was palpable at symphysis 2 finger breadths above the symphysis. Estimated fetal weight was 2.6 kilograms. Uterus is at term and presence of previous lower segment caesarean section scar. As for the vaginal examination, it was normal. The vulva and vagina had no abnormalities detected. The os was dilated to 6 centimeters. The cervix was effaced, soft, it was median and tubular, measuring half a centimeter. The station of the presenting part of the fetus is vertex position. Next, you want to comment on the liqua. The liqua was clear, or whether was there light meconium stained liqua, moderate meconium stained liqua, or thick meconium stained liqua. Inform your medical officer immediately when you see any signs of moderate or thick meconium stained liqua. As for lab investigations, you want to do a full blood count, renal and liver function tests, group screen hold, high vaginal swab in case of PROM or PPROM, as well as a urine FEME. A bedside ultrasound would be important to look at the biparietal diameter, the head circumference, abdominal circumference, the femur length, the amniotic fluid index, fetal heart rate, and the placental position. Now let's take a look at the second case, which is a case of a patient who presented for miscarriage. This patient is a 26-year-old lady Gravida 1 paranil at 9 weeks. Presented with a complaint of having pervaginal bleeding. This patient presented with a complaint of having lower pervaginal bleeding, started 4 to 5 hours ago, associated with lower abdominal cramps. She claims that 2 pads fully soaked with blood clots. Patient was not sure of passing out product of conception but claims noted meat-like content when she went to the bathroom. Patient started feeling dizzy with lightheadedness. She has underlying endometriosis with a history of right cystectomy done 3 years ago. She works in a supermarket and works standing for long hours. So on examination, she was found to be alert with full GCS, pink, not tachypnic, however, tachycardic. A cardiovascular and a lung examinations are normal, and here again you may want to do a relevant examination in accordance to her complaint. So there's tenderness at the suprapubic region with no obvious mass felt. Vaginal examination reveals either an open or a closed os. With speculum, which will be done by your medical officer, you want to look at if there is a possibility to remove the residual product of conception at the os. Lab investigations can be done, and here typically you may want to look at the hemoglobin levels as the patient had history of bleeding. Renal profile, a urine FEME can be done to look at any presence of urinary tract infection that could trigger the situation. And a bedside ultrasound shows no intrauterine gestational sac was seen, or IUGS. And once you have presented your case, you can then end it with a plan given by your medical officer or your specialist. So these are 2 case presentations, a sample in which you can gain some guide to while you're preparing for your presentation. Next, let's move on to progress reviews. So all patients will require a progress review. This means you will need to review patients according to whom you are assigned to. The reviews may be twice or thrice daily, so you would be assigned to beds or cubicles accordingly. Your work usually starts at 7 a.m., but it would be definitely better if you could come in earlier to review your patients prior to your morning rounds. You will need to know the progress and the current issue of these patients from the day before till the morning you see them. So do speak to the patients and ask them how they feel. Also, do not forget to examine them thoroughly because you don't want to miss out any significant findings. Also check on post-operative wounds when given the order to. However, post-LSCS wounds would usually be reviewed during rounds. So, to summarize, the questions to ask yourself is, why is the patient in the ward? How many days is the patient in so far? How many days post-surgery or post-operation? How is the wound today? What have we done in terms of tests and treatment? And what are the future plans or advanced plans? Reviews are done usually 3 times a day by the house officer in charge unless an emergency sets in. AM review is done between 7 a.m. to 9 a.m. PM review is done between 2 p.m. to 4 p.m. and an on-call review is done between 8 p.m. to 12 a.m. Once you have done your reviews, present your review findings to your medical officer who will be doing his or her part of the review as well. There might be changes or additions to your review. Also remember to be at all times reachable, as you know the specialists may have a really busy schedule. So sometimes they may just suddenly come in for rounds, so you would probably want to be around for the patient. Next would be handovers. So a handover occurs when a house officer hands over the responsibility of care for a patient to another house officer, for example, at the end of his or her shift. On average, handovers occur 3 times a day for each patient. Handovers occur at every level of care from the consultants, specialists, and even amongst nurses once their shift ends. So what is the role of a house officer? As a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient is not missed and to avoid wrong information passed over. Past events, which means details of what has been done for the patient as well as the patient's progress for the day or before. Your present plans and events, which includes details of plans that have not been carried out, blood investigations, or formal reporting from radiographic imaging if there's any. And future events would be details of upcoming plans given by the specialist or the medical officer, as well as important or urgent events to look out for on patients' conditions, such as the quantity of pads soaked, drainage after gynecological surgery, dressing conditions, and also the vital signs. So let's now look at orders and requests. When service from another department is required, a request is made. House officers are assigned to make requests following the plans in their daily reviews. So how does a request work? First of all, one has to identify the test that is to be requested for, identify the departments involved, identify then the officer in charge of taking the request from the receiving department, outline the purpose of the request, urgency of the test to be done, and how the test will be able to aid the diagnosis and management of the patient. Next would be to identify the criteria needed for the requested test, and finally, to identify the documents that are required to be filled. To place the request or orders, the steps are as follows. Complete the request form for the test, either manually or through the electronic health record system. Call or meet the medical officer in charge of receiving the request. Once granted, inform the ward nurse on the plan to transport the patient over to the location of the test or collect the specimens for the test requested. Document the trail as to who granted the test and when the test is planned for or preparation steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Now, these are examples of tests that require verbal requests and tests that do not require verbal requests. Next would be referrals. Referrals are made to other departments for their management inputs, suggestions, or if their skill sets are required in the management of a patient. So first of all, you need to identify the purpose of the referral, followed by identify the department that's involved, and then identify the officer in charge of accepting the referrals from the receiving department, which then you will make a phone call to the officer in charge and document the trail at the time at which referral is being made, the indication and the medical officer who accepted the referral. If your referral is not accepted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Now, this is an example of a referral from the obstetrics to the medical department. You should begin by communicating clearly and confidently when introducing yourself. You can start off by saying, "Good morning, Dr. Chong. I am Dr. Ali, a house officer from the obstetrics and gynecology department, or in short, ONG department. I would like to refer to a case of a patient named Puan Sheila, a 32-year-old, para 3, post-emergency LSCS for fetal distress. She has no known medical illness, and during her antenatal checkup, she did not have any underlying conditions too. We noted she started developing mild chest discomfort as well with left calf tenderness with pedal edema too. So on examination, we noted her blood pressure to be normotensive. However, she was tachycardic and slightly hypoxic on room air. Her SpO2 was documented at 95% under room air. Patient is also tachypneic with a respiratory rate of 24 breaths per minute. On her lungs findings, we noted that she has got right basal cause crepitations. We have proceeded with an arterial blood gas and a full blood count, and we have also sent a D-dimer while we wait for the results. The ECG had noted S1Q3T3 pattern. So this is an example of a referral that can be done to the relevant department. You can always end your referral by thanking the team's input and appreciating the team's input on the patient's matter. Next, another important aspect of processes and documentation would be the Pink Book. The Pink Book is the book called the Record Kesihatan Ibu, which is referred to as the Pink Book here. It is used for a periodic health checkup for the mothers. The purpose of this book is to monitor both mothers and fetal's condition. Both medical and psychological and medical needs need to be addressed. This service will be provided and available at all government health clinics as well as some private clinics which have the facility. So, how to get the book and why is it important? A booking is the term used when the first visit is made to a clinic for antenatal care. It is the most important visit to identify and manage medical complications and also to screen for risk factors. So when do you get the book? The recommended time to register for antenatal checkup is before 12 weeks of pregnancy. However, there is no stopping limit even if the patient would like to go in earlier for their booking. So what are the initial steps? During the first visit, patients would be registered with basic details like their address, contact details to make it easier for home visits, their age to assess any possible risk factors, the occupation of the mom and spouse to assess their socio-economic status, the ethnic group to identify possible cultural practices during pregnancy, the number of children, pregnancy, and the year of these previous pregnancies, the age of the previous pregnancy, whether it was carried out in full term, preterm, or prolonged. Any illnesses or complications during the previous pregnancy. This is to identify and anticipate any future problems. The mode of delivery during previous pregnancy and place of delivery. Whether the previous baby was breastfed or given formula feeding. Then, they would be inquired on their gynecological history, which includes their menstrual history, previous surgical procedures done for gynecological purposes, previous pap smear results. Also inclusive in this book would be the past medical and surgical history, which are the underlying medical illnesses such as diabetes, hypertension, and any other chronic diseases. Last but not least, we would also include the family history as it is a significant history. So what are the routine examinations performed? You'd measure the height, and it's measured to estimate the pelvic size, as those who are less than 145 centimeters may have small pelvis and may affect the normal spontaneous vaginal delivery of the baby during labor. As for the weight, it's taken at the first visit as a reference point for subsequent antenatal visits. The blood pressure, physical examination, as well as other routine screening tests such as urine FEME, blood grouping and rhesus factors, blood sugar levels or maternal glucose tolerance tests, full blood count, HIV screening, VDRL, hepatitis B surface antigen, and BFMP for mothers who come in from areas with high risk or endemic for malaria. How about routine ultrasounds? Well, it's usually done twice or more when necessary. The first time is at first trimester to confirm gestational age and to identify any abnormalities as well as the number of fetuses. The second one is during the last trimester to ensure optimal growth, the position of the fetus, as well as the position of the placenta. However, most patients would be scanned more often or even upon their antenatal care follow-ups, and the fetal growth chart would be plotted as well. Lastly, the immunization and supplements needed. Anti-tetanus is given if it is the first pregnancy, and the first dose is around 16th to 20th week of gestational age. The second dose would be 4 to 6 weeks after the first dose. If it is not the first pregnancy, then only the booster will be given. However, if the last pregnancy was 5 years ago, then 2 doses will be given. Routine vitamin supplements will be provided to safeguard the optimal growth of the unborn baby and to prevent iron deficiency anemia. Lastly, let's look at discharges. So a discharge summary plays a crucial role in keeping patients safe after leaving a hospital. Hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. So what are the 6 main components in a discharge summary? Reason for hospitalization, significant findings, procedures and treatment, patient's discharge condition, patient and family instructions, and lastly, the attending physician's signature. And now, what do you need to do prior to allowing your patients back home? You will need to ensure that patient's general condition is well, all plans given by the medical officers or specialists are well carried out. Remember to order discharge medications early so patients will receive them on time. Should there be a need of medical certificate to be issued, inform your medical officer or surgeon in charge to fill the certificate before the patient leaves, as it will be included in their discharge docket. If the patient has been co-managed with other specialties, especially not forgetting the pediatric team, communicate the discharge plan to them. That will be necessary to ensure that there are no clashing plans or appointments. If the patient has a wound, make sure they have an appointment or a memo of wound dressing to be given to the clinic kesihatan or private general practitioner for follow-up of their wound care. And we have finally come to the end of this session. We hope this session was insightful and thank you for your time.